Thanks a lot, Johan, for the introduction. And it's really an honor to talk about among such an unbelievable and very female faculty. I think that also reflects the future a bit of dermatology and research in general. So, dear ladies and gentlemen, dear colleagues, I'm going to talk about disease modification more from a conceptual point of view as well a bit. And these are my disclosures. And the reason why we're actually able to talk about this concept and these ideas is that we achieved unbelievable results with today's biologics that we have with the targeted therapies. Here, just one example, bimekizumab, so one of the newest addition to our treatment arsenal. And you can see here that about 2/3 of the patients that we treat achieve complete clearance. They're just blank. They just don't have any residual disease anymore, and they maintain that efficacy over a longer period of time. And we're able to actually stratify our patients now on an extremely high level. And we do this based on patient characteristics, and I think Nicole Ward's going to talk about personalized medicine. So we're not really there yet to personalize our medicine, but we do stratified medicine. And I'm not 100% sure if we really need that for psoriasis, since we do have such high levels of response. But there might be other diseases where this comes into a factor. But one of the other surprising findings that we did in these biologics or these recent treatments were, and here were example of risankizumab, so an IL-23 blocker. You can see here that they had 3 injections, and this was a very first study, which was still a dose-finding study, so it's not the disease or the dosage that we use today. But you can see even with 90 milligrams, and here also 180 milligrams, you had 3 injections, and then you just stop the treatment. And you have approximately similar results that we saw before with bimekizumab, so about 2/3, 60% of the patients achieve complete clearance. But then 6 months, years would be long, but 6 months after treatment, still half of these patients still remain completely clear. So there seems to be something that really changes the disease course somehow. It really alters how this comes back, or how the relapse should come back. And this was a bit questionable because the half-life of the drug is about 2 or 3 weeks. So this is not explained by the drug which still is there. So there is a lingering effect of this treatment. And a more recent story came out that also showed if we actually have patients did not have yet psoriatic arthritis, and if you treat them with this biologic, and particularly ustekinumab and IL-23 blockers, actually could or might prevent the risk of developing PSA in these patients. So it seems like you can actually really modify the future of these patients. So this is something to look into, even if it's very preliminary. So are we moving towards a cure, or can we at least modify the disease course, be it through preventing PSA, but also reduce really the need for any treatment in these patients? So, and this is one of these patients that we're talking about. So this is a patient in optimized study, so an IL-17 secukinumab treated patient. See very fast response that we are actually expecting already from 17 blockers. So she went on to complete remission, and after a year we actually had to stop the treatment because she had to undergo a very major dental operation. And this was her about 3 weeks ago, now 5.5 years later, and she's not having any topical treatment anymore at all. So no systemic treatment, no treatment at all. She remains under complete remission for 5.5 years. And this is something which cannot be that easily explained. So somehow we really did modify something in her disease. And these observations led to several studies. Now here, one example with guselkumab. So we stopped the treatment, and you see how fast the recurrence or the relapse reoccurs. And here on the left side, you can see again, these were 4 injections. So the last injection at week 20, then withdrawal at week 28. And these were the patients who achieved PASI 90, so a 90% improvement. And you can see about 6 months after the last injection, about 1/3 of these patients remain under PASI 90. So this is, but PASI 90 can be a rather broad response. depending on where the patient started from. So we did a reanalysis from other study, and we saw that if you look at the patients really achieved PASI 0, so 100% response, and then looked at these patients in particular and looked at the absolute PASI, you can again see it about 6 months, a bit more after the last injections. About half of the patients still remain either on PASI 0 or at least below PASI 1. So again, we have a response rate which is not be explained by the remaining drugs which are still in the system. And we obviously looked into what is actually the cause for this maintained efficacy, and some of them were logical, like PASI 100 response at withdrawal time. So more obese patients had a higher risk for a fast recurrency, and trough levels was one of the ones predicting the disease or the response. And a bit surprising at that point was actually disease duration. So the shorter disease duration, the higher is our chances that you actually keep this efficacy despite having no drug at all. And based on this study, Janssen started a study in Germany, the GUIDE study, where they looked into patients who had a short disease duration, so disease less than 2 years, and patients who had a longer disease duration, so more than 2 years. What, from my point of view, is a bit tricky, because a patient who has 1 year and 300 days might not be that different than from a patient with 2 years and 5 days. So I would have probably done like -2 years and +5 years. But nevertheless, even with that, they saw that if you have a shorter disease duration, you have a faster response. You have here in blue, sorry, my pointer is not coming. Here, whoops. So you can see that you have a faster response here, PASI 90, and a higher response rate. And they defined these super responders, which were the patients who achieved PASI 100 already at week 20 and maintained it. And you can see a higher chance to be within these super responders as compared to the longer disease duration. And the one factors which actually defined the chance or risk to be within these super responders or not were not so much the disease onset, the age of disease onset, the BMI, which were factors but not that high. The biggest ones were prior biologics used, and particularly again disease duration. So the shorter disease duration, the higher chance that you actually achieve complete clearance and a faster response. So it really shows that a patient with a short disease duration, so the earlier you intervene in your patients, the higher the chances that they get a fast and complete clearance, but also the higher the chance that when you stop the treatment for whatever reason, that they maintain this efficacy for a longer period of time. And we heard a lot about, the T cells and everything. So we know about disease memory, and these are the ones. So the T cells are the ones which mediate this relapse. That's without a question. We know it's TC and Th17 cells. And if you look into this, and we heard that from Rachel Kroc in the beginning and then confirmed by Liv Weitzmo as well, it's not the central memory which is important, because we have, fixed drug eruption or psoriasis as shown before. It comes back at the very same spot. So this cannot be explained by just the central memory. And what we did, which also influenced then the description of these memory T cells by Tom Copper and Rachel Clark. So we took uninvolved skin from psoriasis patients with these. At that time, we didn't know that these tissue memory T cells transplanted onto a mouse. This then develops fully blown psoriasis just with these tissue resident memory T cells, without the need for any circulating T cells. So we heard that before as well. I'm not going into detail. I just wanted to show you, so there are factors which describe these tissue resident memory T cells. And one of them is, and this heard from Liv just before, was CD49A. And actually what we did some already 15 years ago, we didn't know that this was a marker which defines tissue memory T cells. But if you block this CD49A, integrin alpha 1 beta 1, you can completely block the development of psoriasis. So just by depleting or blocking this tissue memory T cell subset, which I now learned is very messy. And I had a discussion about Liv as well, because we didn't know it was defined to be an interferon gamma producing cell. And we know that actually interferon gamma is not that important, but it's rather IL-17. But it seems like the new immunity paper by Liv, so congratulations as well from my side, actually describes it because they're messy, because they can also produce IL-17, that this is really a key driver in psoriasis. So we know now that these tissue-resident memory T cells remain there in uninvolved skin or in healed skin. They're locally reactivated. They lead to the recruitment of additional T cells, and then you have the clinical relapse. That means if you want to modify disease, if you really want to get rid of these relapses in the long run, somehow you have to get rid of the T cells, or you have them to not produce any IL-17 again and prevent from a new onset of this relapse. So how is this possible? And if you look at the median relapse time, that might give some idea, because you can see brodalumab and IL-17 receptor is a bit different. I'm not going to talk about this, so this is lower, but the others have, like secukinumab and ixekizumab, in the range of about 150 days, a bit more or less. And if you compare that to IL-23 blockers, have about double that. And again, this cannot be explained by just the half-life of the drug. So how is this possible? And one option would be that indeed IL-23 receptor is preferentially expressed on these tissue-resident memory T cells. So is it possible to deplete these T cells? And I mean, Rachel gave the response a bit to that. It's really tricky to get rid of these cells, but there would be an option, and that would be this antibody-dependent cell-mediated cytotoxicity. That means that you still have the IL-23 on the receptor. The antibody comes, activates or targets this T cell which has the IL-23 on it, and then gets depleted. This has never been shown in vivo, so it's highly unlikely. And the other one would be that just the lack of stimulus actually leads that these T cells eventually go away. And I think the two groups that we showed before have shown that it's really hard to get rid of tissue-resident memory T cells, and luckily for us, because otherwise we would have some issues with infections. So this is rather unlikely. So it has been shown for vitiligo. So this was John Harris' group, which showed that if you block IL-15, you can get rid of Th1 tissue-resident memory T cells. I doubt it for psoriasis, because if we have in these patients which have IL-23 blockade, which have ongoing remission, they do not show more infections, because the idea is not just we're not depleting disease-specific T cells, but we would have a broad range of also pathogenic or physiological T cells that would be removed, something we don't have in these patients. So most likely you just switch them over into a more regulatory state in the absence of IL-23. But there's a lot of studies, or at least two bigger ones, which are looking into this. So far, no one has showed remission or removal of these T cells. And as we heard before, there's another option. There's another option to remove the tissue, the disease memory, and therefore potentially prevent the patients from recurrences. And this is not just the T cell or B cell memory, but also inflammatory memory through epigenetic changes. Again, I'm not going into details because we heard it before. I just wanted to explain very, very briefly. So if, for example, you have a primary stimulus which is specific, you activate, for example, monocytes. This then leads to this histone acetylation or DNA methylation that we heard before. But this can be in either way. So this can be trained, so they are sensitized. They have a higher response, so they have a stronger and faster response in the second time. And this second stimulus does not to be specific. But you also have a tolerizing effect in some cases. We know that from recurrent erysipelas, for example, that patients who have recurrent infections, they do not have a need to have like fever or systemic inflammation again in a recurrent infection. So this can be tolerized as well. This has initially been shown particularly for innate immune cells, but as we heard before from Elaine Fuchs and Shruti Naik, also for epidermal keratinocytes. So there seems to be this memory which remains there, and this can also be shown potentially in psoriasis. And there is actually one study which had looked into this. So it was a step-in study from Novartis, where we had a bigger difference between the new onset psoriasis below 1 year. It was very difficult to actually find this patient, but then compared to the ones which have for more than 4 years. And besides looking into T cells and response rates, etc., we also were looking into the DNA methylation patterns. I'm not going to spill the beans here because Johan Gudjonsson is going to talk about this in the second part. But one thing I can say, it looks very promising, and I think this could be an absolute game changer in the future, that we really can actually achieve disease modification, that we can achieve these changes in these patients when we do early intervention. And this is not just for psoriasis, but the general concept. We have HS, which is also a very important disease with a lot of epigenetic changes. So the earlier you actually intervene, the higher the chances you do achieve some disease modification. So very briefly, we have, at least in a subset of patients, we have a clinical effect which is not explained by the remaining drug in there. So there is a disease-modifying effect of these therapies. We heard a lot about the T cells, memory T cells, which are residing in the skin, but also about the epigenetic changes or the inflammatory memory. And again, early intervention seems to be, at least for a subpopulation of patients, really important, and we can potentially modify the disease by preventing PSA development, by reducing the need for treatment in the long run. Now, if this is through preventing or reversing skin or population of the skin through these tissue-resident memory T cells, which might be tricky, or via preventing or reversing epigenetic changing, this remains a matter of debate. But I think this is one of the major points of what the research will be going forward. And this in a few minutes then Nicole will tackle in her talk. So thank you very much, and I'll keep open for questions.
We have some time for questions. Let's see.
Christoph Schlapper from Bern, Switzerland. Hi, Curdin. Thanks for the talk. I have two questions. One, maybe not so serious. What was the dental operation that patient had that you...
She had some implants which were infected, and so they had to remove her, and there were parts of the bones which were removed and replaced. So she really was like for 3 months was undergoing operations. This is also a potential trigger for psoriasis. So we know that just dental hygiene might also have an effect. So I'm not saying that this is not explainable, but you usually have it with acute flares. So this issue with the dental hygiene, more with acute flares, and she had really chronic stable disease. So I don't think that was not the causal effect why she remained under remission.
And then what is known about the molecular mechanisms that drive these epigenetic changes? I mean, the fact that we can block, let's say, 23, and the hypothesis that's in the room is clearly that we prevent the epigenetic modification by doing that. Is it directly downstream of the IL-23 signaling, or is there some indirect mechanism?
I doubt that it makes a huge difference which treatment you're using. I think you need to be very effective, so you have to really remove the inflammation. What Elaine Fuchs and Shruti showed is that one of the factors which lead to epigenetic changes is Th17 inflammation. So it is more prevalent in these diseases. I'm pretty sure we find similar things nevertheless in AD, which, over the disease course completely changes and then it becomes more difficult to treat. But she showed that Th17 inflammation at least is one of the driving factors for epigenetic changes, that these DNA methylation sites remain open.
Chris?
But, yeah.
Thanks, Curdin. Throughout your talk, you only mentioned it once, which was the 4-letter word, which was cure. And but then you insisted on using words such as remission and then disease modification. Do you actually mean cure?
I mean, disease modification is a bit a concept which originated, I think, particularly in Europe early on. And I mean, the rheumatologists, for example, have a completely different concept. For them, methotrexate is a disease-modifying drug. I think for us, it doesn't mean you have to have complete remission. I think it's if a patient in the future or down the road needs much less treatment, potentially also the reduction of comorbidities and so on, this is for the patient disease modifying from my point of view. So if a patient like her, even if it comes back at a given time and you can control her with topicals, for me that was disease modifying. I mean, obviously complete remission is nicer, but I still think she has psoriasis. I mean, if the right trigger probably arises, she probably has a flare again. She still has these tissue-resident memory T cells, I think. So I don't think it's cure. I mean, cure would be if you really get rid of these, all the pathogenesis, you get rid of it, and maybe through CAR T or whatever. But I think as it is just a modification of the disease.
I think we have one other question at the back. Liv, you'll get the speaker in a second. The microphone.
Thank you. That was really interesting. I have more of a conceptual clinical question. So with the step-in study, when it was designed, it was really difficult to decide on who to include. So it ended up with PASI more than 10. So patients who progressed very rapidly during the first year with psoriasis. And it's so clear that most of our patients will have mild disease through life. So early intervention, should we start to treat patients with PASI 4 aggressively for a year? Or where are we heading as clinicians?
I think that's, the issue is a little bit that we're not having access to for all these patients with these very, very effective drugs. But also stepping, they look into phototherapy, and it seems like if you really do proactive treatment, it also has a benefit effect. So I think what we cannot have anymore is that these patients linger around for years, even if they have mild disease, and they're just not treated properly. I wouldn't say we have to go aggressively. I use that word also in the past, but I say that very proactively and see that the patient get proper treatment and potentially going into remission early on. I think that's important. And probably not just as a step for psoriasis. I think that's a general concept for the future. We have to have effective treatments early on for these patients with chronic inflammatory diseases.
Okay. We'll squeeze in one more question. Kathy.
I'll repeat it in a minute.
So once again, Kathy Smith from AbbVie. I couldn't agree with you more about treating early and to really try to cure these diseases. Treating patients with a PASI of 4 would be great, but you have the hurdle of the regulatory agencies and getting the drug paid for. Now, if there could be studies to demonstrate that this early intervention worked, you might get their attention, because then they're you cure the patients or I mean, I go for a functional cure. I mean, a real cure would be better. But once again, everything that's been discussed here and everything I believe, like treat early, treat quickly. And so the counter argument is, well, most of those patients aren't going to progress. I mean, Liv showed the graph where the patients are pretty stable over time. But still, they're going to need medication and treatment. So how do we as a community deal with that? Because in a drug company, this is part of the decision-making process. Do we treat patients with early disease? No, we can't get it reimbursed.
But I think, with the results that we will get from STEP-IN in particular, I think, is that we can show that you can reverse some changes and that this has a prolonged lasting effect. And this will follow up, I assume, or I hope at least, by other studies that will look into patients with, let's say, PASI 4 to 10 that are treated early on, and then see if the idea is not to treat them for 10 years, but maybe for a year. And this might be, cost benefit in the end if you treat them very short, but then you don't have the rest of your life, you more or less have them controlled, but just by topicals. I do get that the companies like that, but I think you also have to, put in some money and do these studies.
Okay.
But I agree. I mean, I think it will come.
Great. Thank you.
Thank you.